So I am Dr. Narayanan Janakiram, and I head the Royal Pearl Group of Hospitals, TRICHY and Hyderabad. Every year, we have been conducting a very special program called the Grand Rounds. So what is this Grand Rounds? Grand Rounds is, I am Dr. Narayanan Janakiram, and I head the Grand Rounds is a kind of mock exam where an examiner will be asking questions to the examinee, and the questions are not given beforehand to the examinee, and it will just resemble a exam, and so it can be replicated, it can be used as a question bank for any postgraduate who is attending the MS or DPEN-B or FRCS exams in ENT. So we from Royal Pearl have always tried to, teach the youngsters, and we believe that knowledge should be propagated. And I have very good friends who actually have the same frequency as me, and I always select the best in the field so that the program is very useful to the whole world. This this caters not only to the Indian community, but also to all across the globe, including all the continents. So this program, Grand Rounds, is very famous. So we generally conduct it in many parts, and always the examiner is Professor Anthony Irdeyarajan. To tell about Professor Anthony is my classmate right from MBBS to MS. And I have known him for the past around 30 years. And I have seen him as a very, very bright student. And he has extensively gone into the depths of reading almost every book in the field of otolaryngology. And so I always call him the encyclopedia of ENT. Professor Anthony is a very to the point professor, and he asks questions which are almost, asked by most of the examiners across this subcontinent. Today, we are going to discuss ATTICOANTRAL disease, which is a long case, and it is going to be the case of discussion. And of course, we have so many questions in this particular field of ATTICOANTRAL disease. And so we're going to divide it into two sections. The first section will be dealt with today, and the second section on Friday. So the same ATTICOANTRAL disease will be discussed on Friday as well, the second part 2. Today, Professor Anthony, who is the professor and HOD of Madras Medical College, the prestigious Madras Medical College, Unit 4, is going to examine a third-year postgraduate who is exam going in the same unit, Unit 4, Dr. Janita Rex. And Janita Rex has always proven to be one of the very, very studious students. And you will see how brilliantly she is prepared for this exam. And without much ado, we will go straight on to the exam. I'm also feeling tensed because, I don't know how many questions I can answer. I'll be watching it very keenly. Now, I just want to conclude by saying it is a very nice occasion because you see the examiner is Dr. Anthony. The moderator is me, Dr. Janakiram, who is Professor Anthony's friend. The student examinee is Dr. Janita, who is Dr. Anthony's student. And more importantly, who is going to moderate the whole session is, you see the smart person there, very smart person, Dr. Shiva. Dr. Shiva also happens to be a product of Dr. Anthony, very brilliant student. And I'm so privileged to have him in Royal Pearl now. but completely trained by Professor Anthony Hridayaraj. And I'm so proud. I'm proud of Dr. Shiva. So over to the three of you, Dr. Anthony, Dr. Janita, and Dr. Shiva. Over to you, Professor Anthony.
Good evening, everyone. Am I audible?
Yes.
Yes, sir.
Yes. Good evening. I'm so happy to be back in the grand rounds this year. This is the great academic activity by Royal Pearl and by Dr. Janakiram, who was a all-round surgeon which I ever known to me. He's such a brilliant student. He's a gold medalist in Madras Medical College, and then he's academically very sound. And if why grand rounds is by Janakiram is because Janakiraman seeks knowledge from everywhere. Any part of the world, anything new, he'll be the first person to go there, see that, and try his hands on it. Whether it is a sleep surgery or whether it is a skull-based surgery or whatever it is. So with Janakiram, when he came to me and say, why don't we do a mock exams, I thought there is no better person than Janakiram to do this. And so, in spite of his busy schedule, he has started doing these grand rounds. And first of all, I thank Janakiram and the Royal Pearl for this opportunity. And then, this is an exam time. When the grand round starts, it tells everybody. There used to be a friend of mine who used to come with me to the beach every Saturday, those days. And if a Saturday is not coming to the beach and is going to the God's place, that means exam is coming near. Similarly, when the grand round starts, that means that exam fever has started, and I wish all these exam going final year students of this year very, very best wishes to do good in the exams. The exams.
I want to interrupt you, Professor Anthony. Before you start this exam, I want to give two feedbacks of your program or maybe our program last year. I want to give two important feedbacks. One lady, doctor from Pune, she phoned up to me and said, I passed my MS exam because of this grand rounds. So this is the best appreciation I can receive, and that too from Pune. She saw this grand rounds, got the questions, and she passed the exam, she said. Number two, another doctor from Mumbai, she rang up and she has written a letter also to me, and she also wrote a letter to Dr. Sriharsha saying that please thank Dr. Anthony, Professor Anthony, because I could clear my DNB exam only because of this grand rounds. So this is the kind of reach this grand rounds has, because this will be on YouTube, and throughout India and throughout the world, people are crazy. They watch this grand rounds before the exam, they watch it. So you please, that's why I requested you, exhaust all the questions, because you have been the examiner for MS and DNB for many, many years. So you have maximum experience. So this is just a feedback. Over to you now.
So I wish everyone the one thing which should come to your mind is that passing an exam may be easy, but reliving the exam or thinking of an exam after 10 years should not bring fear in your eyes and think, oh my God, I fortunately passed the exam. No, not that. You should pass your exams with such a flying colors that you should be very happy to go and talk about your exams. Okay, you can go, and if I become a examiner now, I can go and talk about my exam. I can guess so much. I can tell I have done this, I have done that. But my heart knows how I did my exam. That similarly, everybody's heart knows how they do their exam. So it's always nice to get prepared well and do your exams comfortably. Okay, with this. I am Janita is our exam going MSPG, who we call her a otologist, right? So she is going to present the case, and I wish you best wishes to do good in your presentation and start presenting your case.
Yes, sir. Can I share screen?
She is going to present a case of ATTICOANTRAL disease, right?
Yes, sir. Good evening, sir. Can I start presentation, sir?
Yeah, please.
Sanjay, 15-year-old male from Taramani, a student studying 11th standard, presented with chief complaints of bilateral ear discharge on and off for 5 years, bilateral, hard of hearing, right more than left ear, the right ear for 5 years and left ear for 3 months duration. History of presenting illness was apparently no.
Before we go into the presenting illness, previous slide. Patient noticed history of discharge for 5 years on and off.
Yes, sir.
Okay. So the hard of hearing is only for 3 months on the left ear.
Left ear.
Okay. So this means to say this disease should be more on the right ear compared with that of the left ear. Right?
Yes, sir.
Yes.
History of presenting illness. He was apparently normal 5 years back, after which he had bilateral ear discharge. The right ear discharge was insidious in onset, on and off for 5 years, scanty, purulent, thick, creamy, greenish in color, foul smelling, blood stain associated with blood stain, aggravated with head bath, recurrent upper respiratory infections, relieved partially with medications. The last.
How scanty is that?
At times he was not able to notice it, sir. Only on certain occasions, on probing the ear, he was able to see.
Okay, right. It doesn't come out of the ear. That's a characteristic feature of a scanty discharge. Usually, scanty discharge doesn't come out of the ear canal, right? Yes. When you have a profuse discharge which is coming out, you should always think of there is a superadded infection, or there's a saprophytic infection, or it is because of the tubotympanic disease. Okay, then.
The left ear discharge was also insidious in onset, on and off for 5 years, scanty, purulent, thick, creamy, greenish in color, foul smelling, blood stain, aggravated with head bath in recurrent upper respiratory infection, relieved with partial medication. The last episode was for 1 month back.
Okay. So, what do you want to discuss about the ear discharge?
It's one of the cardinal symptoms of any ear disease.
Okay.
And it shows how chronic the disease is. And depending upon the consistency, color, we can find what kind of disease, whether it's a safe disease or unsafe disease.
What is the WHO definition of CFIM?
Continuous or intermittent otorrhea through a permanent non-intact tympanic membrane for more than 3 months duration.
So, the discharge and the duration got to be measured, right? So, discharge is mandatory, whether it is continuous or intermittent, to say that this patient has got a chronic suppurative urticaria. Secondly, the discharge can come from various areas. Okay, the discharge can come from various areas. For example, a discharge can come from middle ear, or discharge can come from external ear, but not from the inner ear usually. So when it comes from the middle ear, it can be because of an allergy, or it can be because of acute infections, or it can be because of viral infections. Or generally, CSOM has got two types. One is a mucosal type, other one is a squamous type. So what are all the characteristic features you will think about ear discharge, which will help you to differentiate between these two discharges?
The color consistency,
consistency,
quantity,
amount
associated with foul smelling or blood stain.
So generally for a very long case, you will have chronic supraglottic media, usually atticoantral or sometimes tubotympanic. So which can be differentiated. Both the things have got a different types of discharges. So discharges characteristic features are amount, color, consistency, blood stain, and foul smelling. So amount of how you differentiate these two discharges by these characteristics.
Tubotympanic is profuse or copious. Atticoantral is scanty, and the color is greenish for atticoantral, and the tubotympanic can be yellowish or whitish. And atticoantral is usually foul smelling, can be associated with blood stain, whereas the other tubotympanic cannot be. And it's thick, creamy in atticoantral, whereas it's sticky in tubotympanic.
So a discharge which is scanty, greenish in color, thick and creamy, foul smelling, blood stained, usually a atticoantral disease. A discharge which is large amount, profuse, sticky, yellowish in color, not foul smelling, not blood stained, is usually mucosal or tubotympanic disease. Okay, next.
He complains of bilateral hard of hearing, right more than left, insidious in onset, progressive in nature, and it is continuous. In the right ear, it is for 5 years. He was not able to perceive, whisper, and normal conversations. With the left ear, hard of hearing was for 3 months. He was not able to perceive whisper sounds. There was no aggravating or relieving factors. He had complaints of tinnitus.
When will you have an aggravating factor in the case of a ear discharge? A patient who has got a CSIM, will they have a aggravating or relieving factor for ear discharge?
Yes, sir. With the recurrent upper respiratory tract infection, or when there is water entry through the ear, he might have
that will produce discharge. If a patient who has got a tubotympanic disease and have got a hearing loss, every time the patient ear becomes dry, what will happen to the hearing loss? What can happen? In the case of
it can improve.
It can improve usually. When there is no discharge, hearing will be better. When there is more discharge, hearing will be dampened. But it's not true in all cases. It's not true in all cases. When a patient has got a posterior perforation, there is the condition called round window baffle effect. So round window baffle effect is because when the round window is exposed, the patient will have a more hearing loss of the same size of perforation when the round window is not exposed. So that's called round window baffle effect. So when the round window baffle, the ear discharge is there, this will go, instead of the tympanic membrane, this will close the round window, so the hearing will improve. So not always the discharge should reduce the hearing, sometimes it will improve the hearing as well. You understand? Yes. Okay. Then
he had complaints of tinnitus, which was intermittent in the left ear for 3 months. There was no aggravating or relieving factors. He had no complaints of ear pain or giddiness. He had no complaints of exposure to loud noise. No complaints.
So what are the cardinal symptoms of ear disease?
Ear discharge, hard of hearing, ear pain, tinnitus, vertigo.
Why this is a atticoantral disease and the patient doesn't have a ear pain. What does it imply?
He's not going into any complications like mastoiditis or subperiosteal abscess.
CSOM is a painless disease. If the patient develops pain, it may be because of otitis externa, which can be easily identified by tragal sign. If there is no otitis externa, the patient develops pain that is usually due to going for complications. What are all the complications it produces the pain?
acute mastoiditis,
Mastoiditis.
subperiosteal abscess,
Yes.
and the meningitis,
Okay.
subdural hemorrhage, extradural abscess,
Extradural abscess. Extradural abscess is the one condition will have a headache. So when your patient has got a CSOM, multipointer disease, and complains of pain, that's one indication to do a CT scan to find out whether the patient has got a extradural abscess or not. If you don't take a CT scan, then when you do a surgery for the patient, you got to open a tegment at one particular point to see whether there is any collection of pus above the tegment between the dura and the tegment to rule out an extradural abscess. Okay, so that's about the pain. When you don't have a ear problem, you develop a pain in the ear. It's called what?
Referred otalgia.
So what are all the nerves? So what are all the nerves which will cause referred otalgia?
Trigeminal nerve in case of temporomandibular joint disorders or dental pathology. From 9th nerve, Jacobson nerve, and from 10th and 11th nerve, if any laryngeal pathologies, laryngeal pharyngeal pathology. And C2, CT, cervical spine pathology, we can have referred otalgia.
So there are 4 nerves which can produce referred otalgia. That means the problem in some other area, but the patient will have pain in the ear. So one is an auriculotemporal nerve, which is a supply, which is also the nerve, also the same cranial nerve which supplies the oral cavity, dental area, temporomandibular joint. So whenever there is a dental pain, it can be referred in the ear. Second one is the Jacobson's nerve, otherwise called the a branch of the 9th cranial nerve. So any pharyngeal, posterior one of tongue, tonsil, post-tonsillar pain can be referred to the ear. Third one is the external laryngeal nerve, which is the branch of the vagus, which supplies the larynx as well as the piriform fossa, can produce pain in the ear through the Arnold's nerve or an Alderman's nerve, which is the branch of the vagus, which will supply the ear. So the piriform fossa growth or a supraglottic growth can produce pain in the ear without any problem in the ear. The last one is the cervical problems of C2 and C3 can present through the great auricular and the lesser occipital nerves. Then, what are the types of tinnitus? When the patient develops tinnitus, what does that mean?
Inner ear involvement.
Whenever there is an hearing loss, the patient can develop tinnitus. Okay, and if there even a wax in the ear can produce tinnitus, complete blocking wax in the ear can produce tinnitus. But generally, in the case of a CSOM, when the patient develops tinnitus, what are the types of tinnitus you know of?
Subjective, objective tinnitus.
In the case of a CSOM,
Seagulls.
low frequency or high frequency tinnitus. Okay, then whenever the patient has got tinnitus, there is a problem with an hearing and there may be a problem in the inner ear. What about giddiness?
In case of any labyrinthitis or labyrinthine fistula, this patient can present with vertigo.
Labyrinthitis or labyrinthine fistula, patient can have giddiness. Which part of the labyrinth produces fistula commonly?
Lateral semicircular.
Lateral semicircular canal. Very rarely you can have a fistula on the superior or posterior semicircular canal, but the commonest thing is the lateral semicircular canal. Any other part can have fistula, which will have sensory neural hearing loss. Profound sensory neural hearing loss, where you need to do what is there in the center of the mesotympana? Center of the mesotympana. So you have a cochleopromontory fistula. Cochleopromontory fistula can come when the patient has got a mesotympanic colostoma. So that will also cause a sensory neural hearing loss. What are the other causes for sensory neural hearing loss in CSOM?
The toxins released from the infection due to cholesteatoma can go via the oval window, round window, or from the perimatrix inflammation and can damage the outer hair cells, thereby causing hearing loss.
Then cochlear fistula, even a dead labyrinth caused by the invasion of the vestibular apparatus can produce sensorineural laryngitis. Okay. Then what are the other symptoms?
He had no complaints of headache, blurring of vision, no complaints of fever, nausea, vomiting, no complaints of facial asymmetry. He had no complaints of nasal symptoms or throat complaints. Sir.
This patient is complaining of retroorbital pain and double vision. Patient has got a discharge. What do you think of?
Sir, Bredenigo syndrome in case of Petrus appendicitis.
Petrus appendicitis. What is when Petrus appendicitis produces sixth nerve palsy and the retroorbital pain?
Sir,
what are the components? What are the components of Bredenigo syndrome?
First is fifth nerve involvement, that is retroorbital pain, facial pain can be there. Eighth nerve, ear discharge and hearing loss. Sixth nerve, diplopia is there, sir.
It's not eighth nerve. You have profuse discharge. You have a facial pain or a retroorbital pain. Third one is the sixth nerve paralysis, produces diplopia. Okay. Where the sixth nerve is involved?
Dorallos canal. It's nearer to the Petrus apex, sir.
So the Dorallos canal is formed by a ligament. What ligament is that?
Petroclinoid ligament.
Petroclinoid ligament. So the petroclinoid ligament, the nerve goes between the Petrus apex and this petroclinoid ligament. Okay. The extradural axis occurs on the middle cranial fossa. Otherwise, the superior surface of that Petrus bone will have two types of presentation. One presentation when the abscess occurs lateral to the arcuate eminence. Other one is when it occurs medial to the arcuate eminence. Arcuate eminence is an eminence formed by the superior semicircular canal where the dura is adherently attached. So a abscess which connects lateral to this will completely separate the dura from the underlying bone. It is huge abscess. Okay, when the abscess becomes more and more, it keeps on stripping the dura from the bone. That's endosteal dura from the bone. And so it can produce the subperiosteal abscess as well as the extradural abscess, leaving an island of bone in between. That is called Pott's puffy tumor. Okay, so how much ever of pus can accumulate will not produce much of a symptom except pain. If the same abscess occurs medial to the arcuate eminence in a case of apex petrositis, the medially and laterally they are tightly adherent. Medially to the foramen lacerum and laterally to the arcuate eminence. So a pus which forms in between will compress the nerves. So these compression of the nerves will produce sixth nerve palsy. The trigeminal ganglion involvement, and the patient will develop persistent autoria. That is why the patient develops apex petrositis. In a case of apex petrositis, develops Bredenigo syndrome. Okay, so more than blurring of vision, diplopia is important. Okay, then the patient. Okay, next.
Past history. The patient is not a known case of systemic hypertension, diabetes mellitus, bronchial asthma, or pulmonary tuberculosis and epilepsy. There is no history of previous ENT surgery, no history of bleeding disorders or blood transfusion, no history of drug allergy. Personal history. He comes from a low socioeconomic status. He has a mixed diet, normal sleep and appetite, no addictive habits, normal bladder and bowel habits.
Okay. Next.
Family history. There is nil significant family history.
Please go to the previous slide. So when you talk about a personal history and family history, you should also ask about next to the social economic status. You should also ask about the whether the patient is where the patient lives, whether the room is well lit or well ventilated. Why well lit? The sunlight has got a sterilization property. So when there's a droplet infection, it will get evaporated and the bacteria or virus will die fast. If it is not well lit, it will not happen. Similarly, well ventilated rooms carry out the infection easily from the room. Second thing you should ask about is the overcrowding. How many people sleep in the room? How many people live in a room? Okay, if there is a small house of one room where the 4 or 5 people are living, because overcrowding, the cross infection chances are very high. Okay, then why you should ask about the diet? Why you should ask about the diet?
Protein is there in the diet or not? We have
protein-rich diet will always have a good. The people who take protein-rich diet have a less chance for developing the chronic infections. Okay, right. Then next time. Next. Before going to the general examination, what do you think your patient has got?
It's a chronic pathology of the ear because he has ear discharge and hard of hearing, mostly from the middle ear. Must be a chronic otitis.
The chronic infection of the middle ear is called what?
Chronic suppurative otitis media.
Define chronic suppurative otitis media.
It is the chronic suppurative inflammation of the mucoperiosteal lining of the middle ear cleft.
Middle ear cleft of more than 3 months duration. Okay. So, what are the types of chronic suppurative otitis media?
Active, inactive, or mucosal, squamous one.
Mucosal and squamous. What is the basic pathology in a case of a mucosal disease?
In
basic pathology is you have infection of the middle ear. The acute infection of the middle ear is called acute otitis media. That usually heals. Sometimes it will not heal and go for chronicity. Go for chronicity because of 3 types of lesions. One is the tubal pathology. Second one is the tympanic pathology. Third is the tympanomastoid pathology. So, and the infection usually repeatedly goes to the middle ear through 3 routes. One is through the eustachian tube, second is through the perforation, third is through the bloodstream. Okay, the tubal pathology means the perforation comes because of a eustachian catarrh. There will be a closure of an eustachian tube due secondary to the nasopharyngeal infection like nasopharyngitis, sinusitis, postnasal or adenoiditis. So that will cause a tubal pathology. What are the functions of eustachian tube?
To equalize the middle layer pressure. So,
that is called ventilation. That is ventilation. Second is drainage, and third one is the protection. The lining epithelium of the middle ear cleft mostly is the pseudocytophagy ciliated columnar epithelium. The columnar epithelium secretes. The secretion should go to one place. So through the eustachian tube, it goes to the nasopharynx and travels downwards. So second important function of eustachian tube is drainage. So first is ventilation, second is drainage, third is the protection of the middle ear cleft. So always eustachian tube is closed. So anything it come to the nasopharynx, like regurgitation fluid from the stomach or the fluid goes inside the nasal cavity or infection will not travel through an eustachian tube because it is closed always. It opens only in few maneuvers like yawning and swallowing. Okay, so these 3 are the important functions. When this function is not carried out properly, the infection travels inside the middle ear. That's called tubal pathology. Second one is the tympanic pathology. Tympanic pathology is the there's a problem in the tympanic cavity. There may be an oral polyp or persistent infection, or the infection can come to the tympanic cavity by the perforation. A person who has got a perforated drum is not taking care of his um, uh, dry ear. The water enters the ear, it can carry infection to the tympanic cavity. Third one is the tympanomastoid. The infection, the perforation can come primarily because of a acute mastoiditis, and that's the persistent infection in the mastoid will produce mast mastoiditis or chronic mastoiditis, which will keep on producing the infection again, will produce the discharge. So these whole thing together is called the mucosal disease. Okay. So when perforation occurs because of AOM or because of injury, which will cause infection on the middle ear, which persists because of these three, the pathologies will produce mucosal disease. So this usually occurs in the very pneumatized mastoids. If a patient, the mastoid acts as a buffer. The patient has got a poorly pneumatized mastoid. Whenever the eustachian tube is blocked, the patient can go in for two things. One, it can produce secretory arteries media. Otherwise, it will go for negative pressure producing cholesteatoma. Right. So, define cholesteatoma.
Cholesteatoma is a cystic bag-like structure filled with desquamated debris lined by stratified squamous epithelium overlaying a fibrous stoma of varying thickness.
It contains desquamated epithelial debris. Okay, there is a reaction between the stroma and the underlying tissues, which will produce granulation tissue inflammation and can produce bone eroding pathology. Okay, that is the cholesteatoma. Okay, what are all the types of cholesteatoma?
ATTICOANTRAL types pars tensa or pars attic.
Pars tensa cholesteatoma. Pars tensa cholesteatoma or pars flaccida cholesteatoma. So, what type of disease you are doing now? Is there a lesion? Yes, there is a lesion. Where is the lesion? Where do you think this disease is now? Which part of the body? Ear, middle ear, most probably. Okay, so it's what type of disease is that? It's a mucosal disease or a squamous disease.
Squamous.
How do you know?
Discharge, type of discharge.
So type of discharge, it may be squamous disease. Okay. So there is, if the patient is going from complication, the patient has got a complication like facial palsy, headache, or patient develops giddiness, or the patient develops superior synapses or mastoiditis, then you can confidently tell it's a squamous disease. Otherwise, only with the discharge, most probably you are dealing with this squamous disease of various extent. Okay, with this knowledge, bilateral squamous disease without complication, without how much hearing loss you can't guess. So you are going to the examination, right? Okay, present.
On general examination, he is conscious, oriented to time, place, and person, cooperative, afebrile, moderately built and nourished. The vitals are stable with pulse rate around 90 per minute. BP is 110 per 70. Saturation is 99%. Respiratory is 14 per minute. He is not pale, not icteric, not cyanose. He has no clubbing or generalized lymphadenopathy. He has no pedal edema, and the systemic examination was normal. Okay, we're going to ENT examination. Right here, the preauricular region, pinna.
No, if you are going to operate on this patient, which area you are going to operate? You know the diagnosis, and we assume your diagnosis is right. Which area you are going to operate? You tell that ear first. So you can write like this. But when you present, you got to present the disease here first. There's a bilateral disease to present the disease of interest. Okay, if you are going to operate on your left ear, you should present left ear first. If you are going to operate on your right ear, you should present the right ear first. Okay, right, present.
Left ear, preauricular region, pinna, postauricular normal. And there was scanty purulent discharge.
Wait. Preauricular, what is expected?
Sir?
Preauricular, what is expected?
Any
You
tags
look for
can have any
the
osteolar
tag.
anomaly or any anomaly in the middle ear can be suspected if there is.
When you have a congenital anomalies of the pinna or preauricular or postauricular area, there can be other congenital anomalies in the uh, middle ear. Okay, so this is effectively a surgical disease. You are going to operate on the patient. If that is so, you got to be very careful when you are going to operate. Okay, right then. What else you expect?
Any swelling?
Preauricular sinus. Then, when the patient has got an otitis externa, you can have a node.
Straight node.
Node. Okay. What is there? You have a pinna. When the pinna will be pushed outwards, backwards, and laterally. Outwards, forwards, and laterally.
Inferior, outwards, acute mastoiditis.
In case of acute mastoiditis, pinna will be pushed outwards, downwards, and laterally. Laterally. Where will you push outwards and outwards and forwards?
Furunculosis, acute furunculosis.
Okay. Then what is pseudocyst of the pinna?
Serous fluid can collect in between the cartilage and the perichondrium.
Okay. Why is called pseudocyst? On examination, this will look exactly like a cyst, but it's not a cyst. Why it's not a cyst?
It doesn't have a wall.
A cyst is a fluid-containing cavity which is lined by a epithelium. Okay, if there is no epithelial wall, then it is not a cyst. It's a pseudocyst. Okay, right. Then post-auricular region, what are all things you will look for? Any
color change or the groove is any obliteration or deepened.
Yes, when will you obliterate? When it will deepen?
It's obliterated in acute furunculosis, sir. It is ironed out in mastoiditis.
It is accentuated in acute furunculosis. It is obliterated in the subperia's lapsus or mastoiditis. Okay, that is retroauricular groove. What about the mastoid area? How the mastoid area looks like in the case of a mastoiditis or subperia's lapsus?
It's ironed out mastoid.
Usually mastoid, when you palpate, contains a lot of bumps. Right? When you palpate mastoid, you see a lot of bumps. But in the case of a periosteal thickening, which occurs secondary to the mastoiditis, the old bumps will get ironed out. You get a smooth, rubbery mastoid cortex. Okay. Then what is Gressinger's sign?
It is the post-auricular edema, sir.
Pitting edema in the post-auricular region, which is caused by
mastoid emissary vein thrombosis.
Mastoid emissary vein thrombosis, which means what?
The spread has occurred to the infection.
That means patient has got a lateral sinus thrombosis. Okay, patient has got a lateral. What are the other signs of lateral sinus thrombosis? What is the pathology of lateral sinus thrombosis?
There is perisinus abscess, which affects the tunica adventitia, later affects the intima also, and there is thrombus formation in the lateral sinus, which extends in the sigmoid and the transverse. What
is lateral sinus?
It includes both the sigmoid and the transverse sinus.
Sigmoid sinus and the transverse sinus. Okay. So that is the lateral sinus. So first you will get a perisinus abscess. So when the perisinus abscess becomes bigger, inflame the wall of the sinus, there will be a abscess and there will be a roughening of the tunica intima. The tunica intima roughening will cause platelets usually travels in a very smooth, silky area, which roughness it will produce, it will induce thrombus formation. So the thrombus is secondary to the abscess. So the thrombus can propagate. When the thrombus propagate, it can come up to the neck or even can go to the right atrium. Similarly, it can go above, can produce the aortic hydrocephalus. It goes to the straight sinus. So once this thrombus forms, it's an infected thrombus. The center of the thrombus will form the abscess. So slowly it will get ruptured and produces loose infected thrombus material, which will go, and the septicemia will get showered repeatedly in the bloodstream. So this will produce fever, there's a spike of the temperature. This is called, what is the type of fever you get in the lateral sinus thrombosis?
Picket fence.
Picket fence. What is picket fence?
The peak fund.
Those days, when you go to the railway station, there will be an iron what do you call that? There will be an iron wall-like thing which will protect the railway tracks from the from outside. The railway station will be protected by the iron rods. You see the rods, you have it will go up like this and come back. Then you go up and like you come back and go up again. That is the classical picket fence. Picket fence is the one where you have a spike, then normal temperature for some time, another spike, normal temperature, another spike. That is why whenever you have a CSOM, the patient develops fever. You got to mark the fever chart. Okay. So lateral sinus thrombosis can produce, the first symptom may be a Dressinger sign. The patient will have a fever, and then there will be a pitting edema on the post-auricular area. The thrombus, mainly it may be a thrombus, or it can have mainly it will be an abscess. If there's an abscess, the thrombus will discharge, producing showering thrombus. So these thrombus will produce multiple abscesses in the lungs. At the same time, every time the septicemia comes to the blood, you get the picket fence fever. Okay. So the second one is, what is battle sign?
In case of trauma, the bluish discoloration of the post-auricular region is better.
Bluish discoloration of the post-auricular region will be because of the rupture of the mastoid hemispheric vein. Okay, so those days you see this in the battles. Nowadays, where will you see these type of injuries? The road traffic accidents, particularly when the patient is going by a two-wheeler, falls down. Even if he has an helmet, if you have a blunt injury, you can have a battle sign positive. Okay, next. You also should look for any nodes, look for any scars, sinuses, and other things. Okay, right, next.
An external ear had a scanty purulent discharge. There was no swelling. The left tympanic membrane was dull and opaque, loss of cone of light, and hand of malleus appeared foreshortened. The malleolar folds were sickled, and the entire pars tensa was, except the anterior superior segment, which was mobile, it was adherent to the promontory. And there was a posterior superior marginal perforation with irregular congested borders, with the posterior tympanic annulus partially eroded, and the remaining tympanic membrane appeared congested, sir. The perforation site had a scanty discharge over it, and there appears to be a erosion of the long process of incus, with the stapes head appearing prominent. And the pars flaccida is appearing congested and edematous.
This is very poor photo, right? Of course, the photos will be poor only. Actually, what we should have done is we should have put a video. Okay. So, what do you think is the type of disease?
This is a marginal perforation of squamous, unsafe type.
No. Did you see colostoma anywhere?
No, sir. Perforation.
Neuroblastoma is seen.
Yeah.
You feel this is perforation, right? Posterior marginal perforation.
Yes, sir.
Yeah, that's a posterior marginal perforation. What is that your arrow marks shows?
This.
No. Yeah, that. What is it?
This posterior superior tympanic annulus.
You think it's a tympanic annulus? Did you clean that area? Was it bleeding?
Yes, sir. Granulation tissues.
So posterior marginal granulation is the characteristic feature of what?
Cholesterol.
Unsafe. So why there is a granulation tissue?
Sir, as the inflammation, there is chronic inflammation and osteitis occurs, sir. Because of that,
underlying osteitis is the cause of the granulation tissue. Okay. When you see a reddish mass in the external canal, what is the differential diagnosis?
It can be a infected keratosis obturans, external cholesteatoma, or malignant otitis externa in case of floor granulation, or malignancy, external canal malignancy, or a parotid malignancy.
Parotid malignancy. Okay. Okay. Then.
And benign epithelial hyperplasia of external canal.
Okay. Okay.
And middle ear, it can be active otosclerosis showing flamingo sign.
Oh, okay. Very good. Very good. Very good. Middle ear.
Sir?
Comes from the middle ear to the external aortic canal.
Glomus tumor, or
in the case of a CSI,
oral polyp, or
oral polyp, granulation tissue. Then next.
Any darkish blue, like a high-riding jugular bulb can be there.
It can high-riding jugular bulb will be in the intact drum. Okay. What else? Told me glomus, right? What else?
Any malignancy in the middle ear.
Middle ear malignancy. Okay. Then.
Aberrant artery. Any aberrant.
It all will be intact. Drum. Okay. What else? That's all. Eosinophilic granuloma. Then the granulation tissue may not be always chronic granulation tissue. It can be tuberculous granulation tissue. Okay. So these are all the differential diagnoses for reddish mass in the ear. So can you enumerate again?
External ear causes can be either infected keratosis obturans, external ear cholesteatoma.
You can see first is an intact drum with a reddish granulation on the ossicle is called granulosa. Meningitis granulosa is the commonest cause for earbud users to get a granulation tissue. So if you see a drum granulation tissue, you should treat that for a week's time to find out once the granulation tissue comes to, that's an underlying mesotympanic pathology or not. First thing. Second is keratosis obturans or external canal granulation. Third is malignant otitis externa. Where the malignant otitis externa granulation tissue will be
at the bony cartilage junction. At the floor of the
floor of the external aortic canal. Okay. Where will you see the parotid malignancy?
Anterior wall.
Anterior canal wall. You have two fissures through which from the parotid area it can come to the external aortic canal. Then you can get an external aortic canal malignancies and the epithelial hyperplasia which can occur at any one of these places. Then you get an oral polyp and the granulation tissue. Secondary to the chronic suppurative otitis media. Third is then you have a malignant otitis externa. I mean, you have a glomus, you have a eosinophilic granuloma, tuberculosis, middle ear malignancies. Okay. In the case of a CSOM, how will you differentiate it? What's the difference between the polyp and the granulation tissue?
So Polyp is a edematous mucosa, sir. It is pale, smooth in appearance. Granulation tissue is with a irregular granular surface, reddish in color.
It's a edematous mucosa. What is granulation tissue?
It's a reaction to inflammation with
reparative tissue. Reparative tissue.
Reparative tissue formed due to inflammation by the fibroblast neovascularization, multinucleated giant cells, and inflammatory cells.
Inflammatory cells. Okay. Then what is the other difference? Surface.
Surface. This is smooth. Polyp is smooth. This is a irregular granular surface.
Okay.
This is polyp is pink. Granulation is red in color. Polyp is not sensitive and it's non-painful. Granulation tissue is sensitive and painful. Polyp can be probed all over, whereas granulation tissue cannot be probed. And it bleeds. Polyp doesn't bleed on touch. Granulation tissue bleeds on touch. Polyp can arise from any surface of the middle ear, most commonly promontory. Granulation, usually non-draining areas of the ear, it can arise. Polyp is pedunculated, granulation tissue is sessile.
Polyp arises from the. See, what disease the polyp is, what disease the granulation tissue is.
Granulation is squamous, sir. Polyp is tuberculous.
Hello.
Yes, sir.
I'm getting. Okay, sorry. Hello, can you hear me?
Yes, sir.
Sorry, I started getting some other sounds. Okay, so I always say exam is the very lucky situation. Okay, the thing is, a question can ask 2-3 answers, and the answer can change from time to time. Okay, the problem is you might know the answer. Examiner might also know another answer which is also correct, or it was correct previously, or you will know the answer which was correct previously and the examiner will know what is the latest answer. But unfortunately, both of you should know what is the answer. If you don't know what the answer examiner expects, then you will have trouble. Okay, so similarly, what disease is polyp? What disease is granulation tissue?
The granulation tissue is most common in squamous disease, sir.
Okay. Some examiner, old examiner may tell that polyp is a disease of a mucosal disease. But nowadays they say it's also a cause for it's also because of the unsafe ear only. Polyp also an unsafe disease. Okay, but examiner might, some examiner which are all little older time examiner will say it is a mucosal disease. So it can be mucosal or a squamous disease. The granulation disease is because of the squamous disease. Okay, where does the polyp arises from?
From the promontory round window.
Promontory round window. Then see, promontory round window can arise from all areas. So promontory, round window, footplate of stapes, facial nerve, tympanic annulus, hypotympanum, ossicles, and the attic. Attic polyp is those days called as an unsafe polyp. All other areas are supposed to be the pale polyp, but whenever there's a polyp formation, the disease becomes unsafe. Okay, so how will you manage a polyp? We just finished up because it's only a hypothetical. I mean, the answers are, how will you manage a polyp?
Polyps know the site.
Polyp should not be ovals. Okay. Those days they used to use small snaps to cut the polyp. Nowadays, you got to lift the polyp with a suction, see the attachment, and cut the attachment with the micro scissors. Okay, that's how you got to remove the polyp. You should not avulse it. Why you should not avulse it?
It can arise from any important vital structure.
Any important area. There may be a decent hypertympanum that can arise from the jugular bulb, or it can from the facial nerve. If it's attached to the round window, it can cause round window rupture, and the patient can go for sudden sensory hearing loss and giddiness. It can arise from the foot plate. You can avulse the foot plate, or it can get dislocated if you avulse the polyp. So when you see a polyp, you should not catch the polyp and pull it happily. Okay, you got to be doubly sure that where the polyp is attached, then cut and remove the polyp out. Okay, what will you do for granulation tissue?
If it is on vital structures, it can be left, sir. Otherwise, we have to remove it.
You got to manage the underlying disease. When you see a granulation, there's an osteoid. There is no point in removing only the granulation. If you see a polyp, in the case of a central perforation arising from promontory, you remove the polyp and treat the patient medically, the disease may become normal. So then the closure of tympanic membrane entirely depends upon the status of the tympanic membrane and the edge of the perforation. The edge of the perforation is sharp, it can heal by itself. Or if the perforation becomes smaller, you can cauterize and close. But on another hand, the patient has got a granulation tissue. Even if you treat the patient medically, granulation tissue becomes smaller in size. You got to treat the underlying cause. Okay, right. Next slide.
So left ear, there is no tracheal tenderness or three finger tenderness. And
what is three finger test?
So we use three fingers: middle finger, index, and thumb. Middle finger is placed over Simba concha, showing the antrum, and any mastoiditis can elicit tenderness. Index is for the posterior border of mastoid. In case of mastoid thrombosis, we have tenderness. And thumb is for the tip. Any tip infection can show tenderness.
Second finger is?
Sir?
Second finger is on the?
Index on the posterior border of mastoid.
Posterior border of the mastoid. Okay. Actually, I should ask you to show this. Okay. But because it's a Zoom meet, you got to see the book to how to keep all three fingers. How you keep your hand. Okay. What is Zimba concha corresponds to?
It corresponds to antrum.
What is the surface marking of mastoid antrum?
McEwen's triangle.
Yes. What are the boundaries of McEwen's triangle?
Boundary superiorly by the temporal line on the suprameatal crest, anteriorly by the posterior superior meatal wall, and the tangential line joining the posterior wall which bisects the suprameatal crest.
So this is for the features of the boundaries of the McEwen's triangle. How far deep is the McEwen's triangle?
Antrum can be 1.5 centimeter deep to this.
Okay. Can you, if you see that, what is the bony projection which will correspond to the antrum?
Henle's spine, sir.
Henle's spine. How do you differentiate an Henle's spine? Will give you an idea about the pneumatization of the mastoid antrum.
When it's large, it's mostly a contracted small antrum. When it's small, it is a well-pneumatized antrum.
Which antrum you will be happy when you see?
In case of cholesteatoma, sclerosed is better, sir.
Sclerosed is better.
Yes, because it can
cholesteatoma comes in sclerosed antrum. Okay, because sclerosed antrum doesn't have the buffering activity. Okay, so sclerosed antrum, you get cholesteatoma. There's a very limited antrum on the first place, the chances of getting cholesteatoma is very low. Okay, so what are all the theories of cholesteatoma formation?
Invagination theory,
okay.
Or squamous metaplasia, basal cell hyperplasia.
What is invagination theory?
Invagination, by formation of retraction pockets, it can invade, and the
why retraction pocket? You need, one question you should give all the answers. There will be a eustachian catheter, negative pressure, less air in the master air cell system produces retraction of the tympanic membrane. What are the types of retraction you may have?
Attic retraction, posterior superior retraction, sir.
What are the grades of attic retraction?
Attic retraction by Parts Placida's TOS classification.
TOS classification, yes.
Grade 1 is the simple attic dimpling. Grade 2 is the retraction pocket over the neck of the neck of the incus, neck of the malleus. Third is the sputum erosion, partial. Fourth is the total sputum erosion.
So, grade TOS 1 is dimple in the attic. It reduces the Prusok space depth. Okay, type 2 is TM plastered over the neck of the malleus. Okay, grade 3 is partial sputum erosion. Grade 4 is complete sputum erosion. What are the boundaries of Prusok space?
Prusok space bounded laterally by the pars placida and sputum, medially by the neck of the malleus, inferior by the lateral process of malleus, and superior by the fanning fibers of the lateral malleolar fold.
Fanning fibers of the lateral malleolar fold attached to what?
Pars placida.
Fanning fibers attached to the rim of the outer attic wall. Then how can outer attic wall become a lateral boundary? Outer attic wall is sputum and the pars placida are the boundary of attic. For the Prusok space, laterally sharpness membrane, medially neck of the malleus, inferiorly lateral process of the malleus, superiorly the fanning fibers of the lateral malleolar fold gets attached to the rim of the arch of Linnaeus. Okay, so this is the Prusok space. Okay, why the Prusok space is the most important space. The attic colostoma starts in the Prusok space only. If it becomes bigger in size, it partly or completely erodes the outer attic wall laterally and starts eroding the other structures medially, starts from the ossicles. Okay, this is about the first theory. Second one is retraction. Second one is
epithelial migration through perforation. The cholesteatoma can invade and go inside by through the.
What prevents the migration of squamous epithelium from external canal to the middle ear?
The physiological.
What is the barrier? What's the barrier on the tympanic membrane which prevents this migration?
Fibrous layer.
Otherwise called tympanic annulus. So whenever you have a marginal perforation, the tympanic annulus is lost. When the tympanic annulus is lost, there will be a migration of an external canal epithelium into the middle ear, produces posterior superior retraction packet. And the bare bone on the posterior superior area is exposed, causes osteitis, produces granulation tissue. Okay, what is the third theory?
Basal cell hyperplasia, where the epithelium forms cones in the subepithelium region and it goes inside, forming further perforation and entry of squamous depression by the middle ear.
That's an basal cell hyperplasia theory. It forms epithelial cones which becomes bigger in size and ruptures and produces perforation and the colostoma formation. Fourth one is
squamous metaplasia.
Squamous metaplasia theory.
Like
that's the reason for can see a colostoma on a central perforation. You can see colostoma rarely on a central perforation, which is because of chronic inflammation of the middle ear mucosa will go for a squamous metaplasia producing cholestoma. That's the reason for the secondary acute colostoma occurs on a central perforation. Okay. Other theory is the congenital cell rest theory produces congenital cholestoma. Okay. What is mucosal traction theory?
The medial surface of the ossicle and the sorry, medial surface of the tympanic membrane, the lateral surface of the ossicles on shearing forces can produce retraction, thereby causing cholecystitis.
Retraction. There's an epithelial injury on the medial surface of the tympanic membrane, and the tympanic membrane surface of an ossicle can go for adhesion. These adhesions can produce a retraction, can pull the tympanic membrane inside to produce a pockets. These pockets can form colostoma formation. Okay, so these are all the various theories of colostoma formation. Right, next.
Shall I set the other ear or I'll proceed, sir?
You finish the other year and come to this.
Okay. The right ear preauricular region, pinna postauricular region are normal. External auditory canal, no discharge or swelling. The right tympanic membrane, it was dull, opaque, with sickling of the tympanomalleolar folds, with the foreshortening of the hand of malleus, and the lateral process appearing normal. That was great for total global retraction with the TM plastered to the promontory. There was posterior superior retraction pocket with the granulation tissue in the posterior superior quadrant. And the retraction pocket appeared congested with
Okay, forget about this. This patient has got only this attic presentation. The past tensor is normal.
Okay.
This patient has got attic, the same pathology, and the past tensor is normal. What will be the cause for this attic retraction?
The tympanic posterior tympanic isthmus can be blocked due to chronic inflammation. Thereby, the ventilation to attic can be.
So, superior ventilatory pathway should have been blocked. Okay. So, whenever you see a perforation like this only on the attic, that is because of there may be a anterior isthmus might not be present, and there will be a anterior attic diaphragm will be there, and the posteriorly there is the tympanic isthmus, posterior isthmus is blocked because of inflammation, can produce a disease like this. Okay, if there is an anterior part of the tympanic membrane is normal, that just in front of the angle of the malleus is normal. The posterior part of the tympanic membrane and the inferior part has got the same picture. What is the cause?
The anterior epitendinous.
What dysventilation syndrome will produce this type of pathology?
Selective dysventilation.
Hyperselective dysventilation produces the first condition. What is selective dysventilation syndrome?
The anterior and the posterior pouch of the ventral is blocked.
No. So here, to get a posterior superior retraction pocket, there will be an adhesion between the angle of the malleus. There's a retracted drum. Angle of the malleus goes and touches over the promontory and get adherent with the promontory, brings the mucosal traction and the tympanic membrane, vertically from the umbo to the hypotympanum has got adherent, producing adhesive otitis media. So this produces the dysventilation of the whole of the posterior half of the mesotympanum as well as the attic. Understand? If that occurs, you will have a posterior superior retraction. Okay, so this is if you get that will be posterior superior retraction produced because of the dysventilation syndrome, posterior dysventilation syndrome. So, what do you think the pathology in this disease?
Sir, both mastoid and eustachian tube dysfunction. So mastoid is.
Well, it's a global dysventilation syndrome because there's an obstruction to the eustachian tube. Because of the obstruction to the eustachian tube, there will be a global dysventilation syndrome. Okay. Right. Then, next slide.
The tragal tenderness, three-finger tenderness are negative in right ear, and the fistula test is negative. The tuning for test, in the right ear, all the three frequencies, 56, 512, and 1024, the bone conduction was more than air conduction, showing negative ringing. And the Weber was lateralized to right. Whereas in left, only with 256, it showed negative reading. Others were positive. Airborne condition, both the ears were not reduced.
Okay. How do you do various test?
The vibrating tuning fork is stuck against the hard surface and placed first initially over the bone. When the patient stops hearing, he's told to raise his finger. After that, we place the same tuning fork near the ear, 2 centimeters away from the external aortic canal. If the patient hears, it is air conduction is more than bone conduction. If the patient doesn't hear, we repeat the test where we keep first in the near the ear in the external aortic canal. If the patient hears, then bone conduction is better than air conduction.
Okay. Right here, all 3 are negative. Left here, only 2 are negative. Okay. Then 3 by the lateral to the
It is to the right, sir.
right here. Okay, ABC.
It was not reduced in both the ears.
Okay. Then what is next slide?
And the patient
Before that, before that. Slide before that. Fistula test. What is fistula test?
fistula test is where we find any abnormal communication between the membranous labyrinth and the middle ear. So here we either segalize or by tracheal pressure intermittently, we can find the pressure. Because of the pressure change, the vestibular system is evoked or not by this test.
No. This is not the way to do a fistula test.
Alternating pressure or
How you alternate the pressure? Not by tragus.
by Seagull speculum.
Seagull speculum. So, what is Seagull speculum?
Sir, it has a biconvex magnifying lens of 10 diopters with a tightly fitting speculum.
How much magnification it will give?
10 diopters.
10 diopter is the power of the lens. How much magnification it will give you? Two times. Okay. 2 times. Then, what are the uses of Seagull speculum?
We can do fistula test. We can watch for the mobility of the tympanic membrane. We can do powder insufflation test to check whether it is a retraction or a global large perforation or a retraction. For a magnification of the serum, to drain any secretion.
Any secretions. Okay. So usually it is done for one is magnification. Second is to check the mobility of the tympanic membrane. Third is to insufflate antibiotics. Powder insufflation. Then fourth is a powder insufflation test. Fifth is to suck the secretions from the middle ear. Then you do the fistula test. Okay. So how will you do fistula test? So fistula test is done by Seagull speculum or pneumatic bulb is attached to the otoscope and you can do it. So the patient has got a oral polyp, you can press the polyp and see. Or if the patient has got or you can press the tragus. Best way to do is the Seagull speculum. Okay. How will you do fistula test?
By alternating pressures are given to the with a tight fitting Seagull speculum.
First explain the disease to the patient. So tell the patient what all things patient can develop. Okay. You should do the fistula test, make the patient to sit comfortably. Because patient can fall down. You can't do the fistula test, patient standing up. Okay. Make the patient sit comfortably. Then
get her consent Then alternate pressures are delivered, and we watch for nystagmus and any giddiness, and we grade it, sir, by 3 grades. Either one is either nystagmus alone or nystagmus with giddiness is second grade. Third is associated with nausea, vomiting, and fall of the
Patient can fall down, and patient can have a ventricular crisis. Okay. This is about the fistula test. What did that result tell you?
If it is positive, there is a communication.
There is an abnormal communication between the membranous labyrinth and the middle ear cluster. Okay. Then, what is false positive?
False positive, there is no fistula, but we are getting positive. So, it can be by early Meniere's disease because of the dilated sac, we can get giddiness, or with a lax foot plate in congenital syphilis, Hennibert sign, we can get a false positive.
So, false positive is when the foot plate goes very close to the sac, or the saccule comes very close to the foot plate, you get the, without a fistula, you can get the fistula sign positive. Okay, so that occurs in early Meniere's disease, where the dilatation of the endolymphatic system will bring the saccule close to the foot plate. In the case of a lax tympanic, lax annulus, in the case of a congenital syphilis, where they get an hypermobile joints, so you will have a lax annulus. So a hypermobile foot plate which goes abnormally close to the saccule can produce giddiness when the sound is given to the or when the alternate position is given to the patient. Okay, the same thing can happen when there's a loud sound touches the tympanic membrane. So that is called
Tullio's phenomenon.
Tullio's phenomenon. Tullio's phenomenon happens when there's a sound comes. Tell me one other condition where this Tullio's phenomenon and the fistula test is positive, except lateral semicircular canal fistula.
Superior semicircular.
Dehiscence. So that's called third window, or superior semicircular canal dehiscence. Those cases also you get the same reaction. Okay. Then what is false negative?
Negative, in case of dead labyrinth, it can show a false negative, or in case of a cholesteatoma bridging the fistula, we can have a negative, false negative.
Kamali?
In case of dead labyrinth, the fistula, though there is a fistula, it can be negative. Or in other cases where the cholesteatoma is blocking the fistula,
tightly closing the fistula, which is very, very rare. Commonest thing is the dead labyrinth. Okay. How will you know this labyrinth is functioning or dead?
We can do caloric test, sir.
Caloric test. You do caloric test in the CSOM, is it?
Perforation. When there is perforation, we should do air caloric test.
Air caloric test. What tube is used for air caloric test? What is the name of the test? Dundascran air caloric test. Okay. How will you test in your OP? Do you have a Dundascran? Have you seen one?
No, sir.
How will you do?
Cotton wisp dipped in ether can be used as a cold current.
Cotton dip, the cotton dipped in ether and kept on the external canal without ether going inside can produce that. The current can produce, stimulate the air caloric. Okay. Then we will go to fistula test next.
The facial nerve was clinically normal bilateral, sir. Vestibular function tests were normal. No meningeal signs were there. Other cranial nerve examination was normal, sir, bilaterally.
Next.
Examination of nose and throat was normal, sir.
Okay.
Posterior rhinoscopy showed adenoid hypertrophy. And oral cavity examination was normal, sir.
Okay. How is the palate?
No No high arch, normal palate. No high arch or any defect
You are,
or cleft.
you are seeing a patient who has got a bilateral unsafe disease. That means, what does that imply?
Chronic eustachian
There's
tube disease.
chronic eustachian tube block on both sides. What may be the reason? With your clinical symptoms and signs, what may be the reason?
Sir?
What is the reason for the bilateral? What is the probable reason for the closed
Adenoid hypertrophy, sir.
adenoid hypertrophy? Okay, so there's adenoid hypertrophy, closing eustachian tube on both sides. What you are expected to have?
Block in the eustachian, ventilation is affected. If it's a
What
contraction.
will happen to the patient?
Snoring.
Snoring, sleep apnea, long-standing adenoid hypertrophy produces adenoid phases. I will look for adenoid phases.
I looked, sir, there was no high arch palate or nose bridge. No, sir.
Okay, so you should have looked for IX, flattening of the nasolabial fold, protruding lips, pinched up nostril, pinched up lips, protruding teeth, and then long face, elongated face. What do guy is aphroxia?
Sir?
What do guy is aphroxia? Dull look on the patient. So I told you are an otologist. You don't read other subjects. Okay, right. What's your diagnosis?
The bilateral chronic otitis media with active squamous cell disease, with the right ear with severe hearing loss and left ear with mild hearing loss without any intracranial complications.
So, left ear is inactive.
Left ear was active, sir. Right ear, there was granulation tissue and minimal discharge.
You told me active squamous cell disease right here.
No, sir. Bilateral, sir.
Bilateral, both sides is active.
Yes, sir. Right side, there are retraction pockets. However, because of the granulation tissue, I thought it was.
I asked you which ear you will operate. Present that first. Which ear you are going to operate? Left ear going to operate. Why?
Because it was active compared to the right ear, sir.
What is active? Disease.
With discharge.
So right side you have discharge.
Left ear had.
How long patient had hearing loss on left side?
3 months, sir.
How much hearing loss on right side?
Severe.
5 years.
Duration 5 years.
5 years. Which is a severe disease?
Right side, sir.
Right side. And then which year the hearing loss is more?
Right side.
Right side. So which year is an active disease? When you look at the tympanic membrane, what's your diagnosis of right ear?
Global retraction with attic retraction and posterior retraction topics, sir.
Left side?
Sir?
Left side?
Left side, it was a posterior marginal perforation with grade 3.
Only posterior retraction bucket. If it is an attic, see, how will you select which ear you will operate?
When it is attic or a posterior superior retraction pocket, we go for posterior superior retraction pocket because
wait. First, if you have both one side unsafe ear, one side safe ear, which ear you will operate?
Safe, unsafe ear.
Unsafe ear. Okay. And then if you have both sides unsafe ear, which one you will operate? One side is an attic perforation, other side is a posterior superior perforation. Which side you will operate?
Mesotympanum has more complications than attic. So
you do a posterior superior. Okay, in this case, what is the disease on right side?
Right side, both attic and posterior superior.
Attic and posterior superior. Left side?
Just posterior superior, sir.
Then which one will operate?
Right here.
Right here. Okay. If both the things are all posterior superior, or both the things are attic, or both the things are both, which area will operate?
Whichever is active.
No. Active disease will not come in the atticoantral disease. Okay. So, if which ear is more hearing loss, you will operate. Which ear there is
Right
more
ear.
hearing loss, you will
Right.
which ear is going for impending complication, you will operate. Or if you take a CT scan, which ear there is a more disease, you will operate. Okay. The patient might ask left ear because patient has got discharge now. But the bigger disease profile is the right ear. Okay, so why you operate on a left ear, on a posterior superior ear than the attic ear?
More important structures are near the mesotenum, like facial nerve. After ossicular injury can be there, sir. After that, can go to facial nerve injury, and fistula, labyrinthine fistula can be there. First,
Why attic disease? Why attic disease is dangerous?
it is lined by cuboidal epithelium, so any injury can cause granulation, sir. That can go into other things are like overcrowding, poor drainage, and important vital structures are present in the attic.
Important vital structures are what?
Sir?
What did you tell? Important?
Vital structures are there in the attic, sir. Lateral symptoms
Are close to the attic. Isn't it? Then why you want to operate on a posterior superior? First is attic is lined by cuboidal epithelium. An injury to the cuboidal epithelium produces granulation tissues which erode the bones, produces complications. Second is vital structures like tegmen, lateral semicircular canal, facial nerve are all close to the attic. Third is attic ventilation is poor because it mainly depends upon two openings called isthmus tympanicus posterior and isthmus tympanicus anticus. So because of the poor drainage, because of poor ventilation, there's a poor drainage. Whenever there is an infection occurs there, it will not get drained easily. Okay. So because of these conditions, attic disease is unsafe. Okay. But you take between an attic and the posterior superior, the posterior superior disease goes to the attic. Or an attic disease comes to the posterior superior area. So once the disease becomes bigger, the picture is different. Okay. So how does the attic cholestoma spread?
Attic cholestoma spreads to Krusak's space. From there to the superior inferior space, lies lateral to the body of meniscus, and from there it goes to adductus and mastoid. Whereas posterior superior retraction pocket, it goes to the inferior space, medial to the body of meniscus. From there it goes to attic.
How it goes to the inferior space?
Like posterior tympanicus isthmus, it goes to the medial inferior space. Medial, sorry, posterior superior retraction pocket can go to the hypotympanum, sir, first, like through sinus or facial research.
You didn't tell me that about the attic. Attic can spread anteriorly, posteriorly, inferiorly. You told only the posterior pathway. Anteriorly?
Anteriorly, through anterior pouch of Montroche or posteriorly to the posterior pouch of Montroche, it can spread, sir.
Spread to where?
Anterior mesotympanium and posterior mesotympanium.
Okay. So inferior spread is through the anterior pouch of Montroche and posterior pouch of Montroche. What is the boundary of anterior pouch of Montroche?
Laterally by the tympanic membrane, medially by the anterior malleolar fold.
Okay. Posterior pouch, similarly, posterior, same thing, tympanic membrane and the posterior malleolar fold. So if everything is lateral, okay, lateral to the body of the meniscus, close to the tympanic membrane. So basically, an attic cholestoma is a lateral cholestoma. Okay, the vital structures are medial to them. Okay, so its pressure on the medial wall is relatively later compared to that of the posterior superior retraction pocket cholestoma. So, what is the SADS classification?
Says it's for pars tensa, sir. First is retraction, minimal retraction. So it's a near contact with the long process of incus. Next is the total contact with the long process of incus. 2 is 3 is atelectatic ear. 4 is adhesive ear over the
So
promontory.
first thing when it happens is it tends open over the it touches the long process of incus. Then it touches the medial wall. So it can erode the bone, or it goes to the medial wall of the middle ear cavity. From there, posterior extension, it goes to the sinus tympani and facial recess on the posterior mesotympanum. What are the boundaries of facial recess?
Medially by vertical port of facial nerve, laterally by collar tympani, superiorly by fossa inferior.
What is fossa inferior?
Which holds the short process of incus, sir.
Okay, it forms the inferior border of the adytus. Okay, where the long process, the short process of incus comes and lodges. So that is the first vertical groove on the posterior wall of the middle ear cavity on laterally. Okay, what is sinus tympani?
Sinus tympani is it's a space in the retrotympanum. Medially, it has the promontory. Laterally, it has a vertical port of facial nerve. Superiorly ponticulus and inferiorly subiculum.
Inferiormedially?
Round windows, sir.
Okay, what is ponticulus?
It's a upper extension from promontory, sir. Bony projection extending from promontory superiorly.
Promontory at the level of the lower end of the whole window to the promontory. Okay, what are the types of ponticulus?
Complete, incomplete, absent. 3 types.
What is complete?
It is like a dam, sir.
It's like a dam. It separates the sinus tympani from the posterior sinus. There is no communication. So if there is a retraction at the posterior superior, it stays only on the posterior superior. It will not go to the posterior sinus. Okay. So through the sinus, what are the types of sinus tympani?
First 3 types are there. First is at the level of facial, then can go to medial to facial, third can go retrofacial. So
one is flushed with that of the shallow, flushed with that of the facial nerve. Second is goes medial to the facial nerve. Third is goes retrofacial, deep inside. Okay, so that's about the various types of sinus tympani. Okay, so when the posterior mesotympanic colostoma retracts, it retracts to the posterior wall. From the posterior wall, it goes to the sinus tympani and the facial recess. So it can travel downwards to the hypotympanum. Okay, then it can travel upwards. Upwards, it can travel through the isthmus tympanicus posticus. It goes into the inferior incrural space, which is medial to the body of the incus. Then adytus et antrum to the mastoid axial system. So when you see the difference, the superior incrural space, superior incrural space is lateral to the body of the incus. Inferior incrural space is the medial to the body of the incus. An attic colostoma goes lateral to the body of the incus. A posterior superior colostoma goes medial to the body of the incus. The importance is when you do an atticotomy for a colostoma, if you see a incus is intact, then you can, if it's an attic colostoma, you need not go beyond the incus. So the vascular chain is intact, you can leave it. But if it's a posterior superior retraction pocket colostoma, if you see an incus is intact, still you got to remove the incus to look for the colostoma traveling medial to the incus. Otherwise, you got to necessarily open the mastoid axial system. Okay, so what you think you should remember is in the case of a posterior superior retraction pocket colostoma, it is directly over the medial wall of the middle ear cavity, goes to the attic. So in between you have the facial nerve, you have the footplate of stapes. So what is the first bone which will get eroded in the colostoma?
Lenticular process of mucus.
Lenticular process increases the first bone which will get eroded. Why lenticular process is getting eroded early?
And anastomosis is between stylomastoid branch and the arteria nutrica incudomalleolar branch from the superior tympanic branch of middle meningeal artery.
It's a long artery. It's a superior tympanic branch of the middle meningeal artery from the head of the malleus, comes along the articular chain, comes to the lenticular process. The name of the artery is arteria nutrica incudomalleoli. So it gets anastomosed with the another long artery from the stylomastoid foramen, post-auricular artery, stylomastoid foramen, which comes through the stylomastoid foramen, comes over the stapedius tendon, comes and supplies the stapes and also a part of a lenticular process. So because of this long blood supply, an infection can suddenly cause necrosis, can produce lenticular process necrosis. Even a retracted drum, intact retracted drum without cholestoma and a long-standing retraction can cause erosion of the lenticular process. Okay, how does cholestoma erodes bone?
Various mechanisms like pressure necrosis, hyperemic decalcification, enzyme activity, vicarious blood supply, and
what is hyperemic decalcification is called?
Hysteresis.
Hysteresis. It's called hysteresis. Okay, so cholestoma can cause pressure necrosis, hyperemic decalcification, enzymatic osteoclastic activity because of the stimulation of the macrophages produces giant nuclear cells. And the last one is the vicarious blood supply. So vicarious blood supply is not usually an accepted theory, and the pressure necrosis is not usually an accepted theory. Accepted theories are pressure necrosis causes local acidosis, which will increases the blood supply. The blood supply will cause the taken away of the calcium, leaving behind the matrix and the cells. The giant nucleus, multiloculated giant cells will come, have an osteoblastic and osteoclastic activity. Osteoclastic activity is more compared to osteoblastic activity, so it eat away all the osteocytes and leaving behind the matrix, which will get absorbed by the proteolytic enzymes like elastase and collagenase, which is secreted in the due to the inflammatory inflammatory cells. Okay, so this is how the cholestoma gets eroded. So which year you will so your diagnosis will be bilateral chronic otitis media, squamous disease. Okay, right ear, posterior superior and attic cholestoma with the severe conductive hearing loss, and left ear with the mild conductive hearing loss with a posterior superior perforation and granulation without any intracranial complications. So now you tell me which ear you will operate?
Right ear.
Right ear. Okay. So what will be the pneumatization status of the this patient?
Must be bilaterally sclerotic, sir.
Sclerosed mastoid. Because bilateral disease. So will you take X-ray mastoid for this patient?
Yes, sir.
Which side you will take?
Both sides.
What information you will get? Why you take X-ray mastoid?
To look for any sclerosed margins, sir. Cholesteatoma sac, cholesteatoma cavity is present or.
First is to look for sclerosis. When you take both sides, if one side is diseased, other side is normal, And normal side you get a cellular mastoid. The disease side you have a sclerosed mastoid. Then you will think the sclerosis is because of mastoiditis. That occurs in the mucosal disease. Okay. In the case of atticoantral disease, X-ray mastoid will tell you where all the diseases spread. Okay, and then you look for the anatomy of the patient. So anatomy is you see the low-lying dura, forward-lying sinus plate, contracted antrum, and then you look for whether there is any cavity. Okay, if there's a cavity, you look for the margins of the cavity. Why you look for margins of the cavity?
Either smooth walled or irregular. You can find previously operated cavity can be distinguished.
Okay.
A lot of other conditions like tuberculous cavity or glomus.
Okay. And what other condition produces cavitating lesions?
Eosinophilic granuloma, sir. Cholesteatoma cavity. Previously operated cavity. Large antral cell.
How will different a large antral cell with the operated cavity?
It will be other cells. Pneumatization can be seen. The other cells will be there. It will be the largest cell.
There will be very pneumatized mastoid for a large antral cell. Okay. But operated cavity should be usually single and a very small amount of cells and the other areas. Then, what is the cotton wool appearance?
In case of cholesteatoma, the mastoid shows a cotton wool appearance with the rounded sclerosis. No.
What is eosinophilic granuloma? Eosinophilic granuloma is a manifestation of an histiocytosis X. Histiocytosis X can be a generalized disease or a localized disease. Generalized disease, Arshel, Anschel Christian disease. The localized disease can be an eosinophilic granuloma or a multiple myeloma. Temporal bone histiocytosis is called eosinophilic granuloma. Okay, where it produces granulation tissue and produces cavitating lesion. Okay, how will be the what is the characteristic feature of tuberculous otitis media?
You'll have multiple perforations, pale looking granulation.
How will be the discharge? There will be a watery discharge. What is another characteristic feature? Patient will go for complications more for the disease. The amount of the disease will produce this for that amount of the disease. There will be an exaggerated complications and exaggerated hearing loss. You'll have a small perforation, the patient will have a severe hearing loss. So those are the points which will raise you high index of suspicion for a tuberculous patient, which is slowly becoming lesser. Patient can also have a active tuberculous lesion in the lungs. Okay, so Janakiram? Hello.
Hello, sir.
Yeah, it's almost 2 hours now. Can we stop today and go for the management in the next class?
Yes, sir. Yes, sir.
Okay. So, Janita, we'll see you on Friday. I'll tell you the time, so you can you got to present the rest of the examination on Friday. I thank Janagaraman profusely for making efforts to do this grand rounds, and I thank Janita, Siva, Deepak, and all the participants. And I expect you to participate actively in the chat. Okay, we will meet you on Friday. Any conclusion remarks from host?
Thank you for the wonderful brief description about anatomy and up to diagnosis of ear cases, sir. We'll meet in Friday for your. I'm expecting more. I'm eagerly waiting for your surgical explanations, sir. On Friday.
Hey, நீ present பண்ண மறந்துட்டியா?
Sir.
Okay, thank you everyone. Thanks for your patient listening. Thank you.
Thank you so much, sir.
Thank you, sir.